Welcome back to the podcast, everyone. Today, we are diving into a clinical sign that looks like a literal warning light on a patient's arm. We're talking about lymphangitis and that classic red streak sign. Dr. Sarah, are you ready to get into the weeds or maybe the vessels with this one?
I am indeed, Dr. Khan. While the visual is striking, the anatomy behind it is incredibly consistent, which makes it a favorite for board examiners. When we see that red line tracking up a limb, we aren't just looking at an infection. We are looking at a map of the lymphatic system in real time.
I love that. It's like the body's own GPS. Now, why does this matter clinically? Well, if you see that streak, you aren't just dealing with a local skin infection anymore. Think of the lymphatics like a city's sewer or drainage system. Normally, it's invisible and does the dirty work of moving fluid and waste quietly. But when it gets overwhelmed or infected, the pipes themselves become inflamed. That's lymphangitis.
Exactly. And for the STEP exams, the distinction between the superficial and deep lymphatic systems is key. The red streaks we see are specifically involving the superficial lymph vessels. These vessels originate in the skin and follow the superficial veins. Dr. Khan, give us a clinical scenario where this shows up.
Classic case. A gardener comes in after getting pricked by a rose thorn on her index finger. 2 days later, she's got a painful, hot red line running from her hand right up the lateral side of her forearm, heading toward her shoulder. Now, Sarah, looking at our anatomy, why is the lateral versus medial path so high yield?
This is a big one. If the infection starts on the thumb or the lateral side of the hand, those lymph vessels follow the cephalic vein. They track up and usually bypass the elbow to drain directly into the infraclavicular or deltopectoral nodes. But if the infection is in the middle, ring, or little finger, the medial side, the path changes.
Right, those medial vessels follow the basilic vein. And here is the gotcha for students. Those medial vessels stop at a checkpoint just above the medial epicondyle of the humerus. What do we find there, Sarah?
The supratrochlear node. If you have a patient with a red streak on the medial forearm, you must palpate just above that funny bone area. If that node is enlarged and tender, which we call lymphadenitis, it confirms the medial drainage pathway. From there, it moves into the lateral group of axillary nodes. It's brilliant. I always tell my residents, the anatomy tells you where to look for the fire. If the fire's in the little finger, check the supratrochlear node. If it's in the thumb, look toward the infraclavicular nodes. Why does this matter clinically? Because if you miss the enlarged node, you might miss the extent of the infection. This isn't just a skin rash. The bacteria are literally hitchhiking toward the bloodstream. And we have to talk about the who. When you see these red streaks, what organism should immediately jump to mind for the boards? In most cases, it is Streptococcus pyogenes, group A strep, though Staphylococcus aureus is a close second. Occasionally, if that gardener was actually bitten by a cat or dog, you might think of Pastorella, but strep is the classic answer for lymphangitis. And remember, lymphangitis is a race. If you see that streak moving toward the axilla, you need to act. If it hits the apical nodes at the very top of the axilla, it's only one step away from the subclavian lymph trunk, and then boom, it's in the venous system. Now you're dealing with sepsis. When you catch this early and stop that progression, that's when you really become the doctor of choice for a worried family. Let's talk about a common mistake. I often see students confuse lymphangitis with simple cellulitis. How do you distinguish them at the bedside, Dr. Khan?
Think of cellulitis like a spilled bucket of red paint on the floor. It's a diffuse, spreading area of redness with no clear path. Lymphangitis is like a single brushstroke of paint. It's linear. It follows the highway of the lymph vessels. Also, the tenderness in lymphangitis is usually right over the streak itself and the regional lymph nodes, whereas cellulitis is tender everywhere the skin is red.
Precise as always. Let's do a quick recap of the node check. For the axilla, examiners love the 6 groups. If the infection is coming from the arm, it hits the lateral group first. If it's coming from the breast, it's the pectoral group. But ultimately, all roads lead to the central and then the apical nodes.
Exactly. And for those listeners in the clinic, don't forget that these patients might also have inflammatory edema on the back of their hand. Because the lymph vessels of the palm mostly drain to the dorsum of the hand before heading up the forearm, a palm infection can actually make the back of the hand swell up like a balloon.
That is a great pearl. It's easy to think the infection is on the back of the hand when the real culprit is a deep wound on the palm. So if we summarize for the boards, look for the red streak, identify the drainage path, lateral thumb to infraclavicular, medial fingers to supratrochlear, and remember that group A strep is usually the driver of the bus.
Perfect. Why does this matter clinically? Because a red streak is a call to action. It tells you the body's defenses are being tested in real time. Catch it, treat it, and keep that infection out of the central circulation.
Well said. The take-home message, follow the line, find the node, and treat the strep.
Thanks for joining us today in the lab. We'll catch you on the next episode.